She is 69 years old, and she has been on her Medicare Advantage HMO for 4 years without a serious problem. Then, on an otherwise ordinary Tuesday in March, her doctor says the words nobody wants to hear: early-stage breast cancer, caught it in time. Treatment is possible. The prognosis is reasonable. And her first instinct, a sensible one, is to call and switch to Original Medicare with a Medigap supplement so she can see any oncologist in the country without referrals, without prior authorization battles, without a network standing between her and the best care available. The agent is polite. Yes, she can leave her Medicare Advantage plan. That part is straightforward. But to buy a Medigap supplement, the coverage that makes Original Medicare actually work, she'll need to go through medical underwriting, and a fresh cancer diagnosis is, in virtually every state, a near certain denial. She can walk out the door. She just can't walk back into what she gave up. Right now, more than 30 million seniors are on Medicare Advantage, more than half of all Medicare enrollees. Most of them got in easily. Getting out is a different story, and 2 questions are worth holding on to as we go through this. Why does a plan that now costs Medicare more than Original Medicare keep growing at this rate? And what exactly is the mechanism that makes leaving so hard? And why does no one explain it at enrollment? Medicare Advantage was introduced as a cost-saving experiment. The logic was clean. Let private insurers manage care more efficiently than the government, and Medicare spends less per member. For a brief window in the early years, the numbers supported that idea. Then, something flipped. Today, Medicare pays private insurers roughly $1,000 or more per member per month, a fixed capitated payment, regardless of how much care that member actually uses. The insurer profits by keeping actual care costs below that payment. And the more members they enroll, the more capitation revenue flows in. That revenue funds the television commercials with the 1-800 numbers. It funds the celebrity endorsers. It funds the mailer's time precisely to open enrollment. Every new enrollee is a new revenue stream, and the marketing budget reflects that math. The $0 premium isn't insurer generosity, it's a loss leader, funded by Medicare's capitation payments, customer acquisition at scale. This isn't inherently corrupt. But here's the thing. The incentive structure matters enormously when the entity that profits is also the entity deciding whether to approve your MRI. So what does that incentive structure actually look like inside the plan? Now the network reality gets specific because it operates in layers, and each one is worse than the last. The first layer, the quiet elimination of PPO options. Plans that once offered out-of-network access have systematically reduced those options through what the industry calls service area reductions. Most Medicare Advantage enrollees are now in HMO-style structures with strict network requirements. The flexibility that was advertised at enrollment has, in many cases, simply been contracted away. The second layer, network instability. Doctors and entire practices can leave a network mid-year without warning. A senior who enrolled specifically because her cardiologist was in-network may find that cardiologist gone by February. The plan hasn't changed on paper. The coverage she thought she had has quietly disappeared. The third layer, the referral chain. HMO models require a primary care referral before any specialist appointment can be scheduled. If your PCP has a 3-week wait, the specialist clock doesn't even start until that referral exists. That's weeks of delay before the first available appointment is even visible. Contrast that with Original Medicare. Any doctor who accepts Medicare anywhere in the country, no referral required. For retirees who winter in Florida or spend months traveling, the gap is even sharper. Medicare Advantage coverage outside the service area is emergency only. A fall in Phoenix when your plan is based in Ohio is a billing nightmare that takes months to resolve. Prior authorization is usually described as a bureaucratic inconvenience. That framing is too generous. It's more accurately understood as a financial instrument. When a Medicare Advantage insurer denies or delays an MRI, a CT scan, a course of post-surgical rehab, or a specialty drug, it reduces the claim cost for that period. Because the insurer receives a fixed capitation payment regardless of what care gets delivered, every denied claim is margin. This is not speculation about intent. It is the structural logic of the model. One comment from a medical billing professional describes an HMO that denied ambulance service as not medically necessary. The patient died in the ambulance. The family received the bill. That comment collected 58 likes, not because the story is shocking, but because it's familiar. MRIs for back pain, post-surgical physical therapy, durable medical equipment, specialty medications, all subject to prior authorization in most Medicare Advantage plans. The process requires the doctor's office to initiate the request, document the medical necessity, wait for a decision, and sometimes appeal a denial. Physicians who treat Medicare Advantage patients describe it as a second job. Some stop accepting Medicare Advantage patients entirely, which quietly shrinks the effective network further without any change to the plan documents. The downstream effect is care that was technically covered, delayed long enough that outcomes worsen or patients simply give up. But here's what almost nobody understands until it's too late, and this is the part nobody explains at enrollment. At initial enrollment, when you turn 65, you have a guaranteed issue right to buy any Medigap supplement on the market. No health questions, no underwriting. You are, in that window, medically invisible to the insurer. If you choose Medicare Advantage at 65 and stay healthy for several years, you can return to original Medicare during the open enrollment period. That part is straightforward. Here is where the door closes. Original Medicare alone has no out-of-pocket cap. Without a Medigap supplement, you're exposed to 20% co-insurance on everything. Every surgery, every hospitalization, every specialist visit with no ceiling. So leaving Medicare Advantage without securing a Medigap plan doesn't solve the problem. It trades one risk for a worse one. And getting a Medigap plan after your initial enrollment period in most states requires medical underwriting. If you've developed cancer, heart disease, diabetes, or any significant chronic condition while on your Medicare Advantage plan, the exact conditions that made you want better coverage, you will in most cases be denied or priced beyond reach. The states with continuous guaranteed issue protections are Connecticut, Massachusetts, Maine, New York, and potentially Vermont and Washington. 5 states, roughly, out of 50. Federal guaranteed issue rights exist only in narrow circumstances. Your plan exits your service area entirely, or your insurer goes bankrupt. That's it. One Medicare counselor describes the calls this way. I get calls all the time. My sister is on this MA plan, and now there's an issue and we need to get her off. You can't get her off. You can walk out of the plan. You cannot walk back into the coverage you gave up. It's worth being honest about when Medicare Advantage actually works, because the pattern tells us something important. Kaiser Permanente seniors report consistently different experiences. The reason is structural. Kaiser is an integrated delivery system where the insurer and the provider are the same organization. There are no prior authorization battles between insurer and doctor because they're the same entity. That is fundamentally different from a major national carrier contracting with independent physicians across a fragmented network. Long-term members who've had the same plan and the same medical group for decades, who rarely need complex care, they've never stress-tested the system. The plan works because the plan hasn't been asked to do much. And in competitive urban markets with multiple Medicare Advantage plans competing for the same providers, network quality and referral responsiveness genuinely improve. Then there's the poverty angle, and it matters. For a senior climbing out of financial hardship, a Medigap premium, even a modest one, isn't a trade-off. It's an impossibility. The $0 Medicare Advantage premium isn't a trap for someone who genuinely cannot afford the alternative. It's the only door that's open. The one-way door matters most for the people who entered not by preference, but by necessity, and who have the least capacity to absorb what happens when the plan fails them. So what do you do with this? If you're not yet enrolled, you have a guaranteed issue window at initial enrollment. That window is the moment. Understand it, use it, and don't let a $0 premium make the decision for you before you've seen the full picture. If you're on Medicare Advantage and currently healthy, investigate whether you're in one of the 5 guaranteed issue states. If you're not, Understand that your window to switch may close with your next significant diagnosis. Annual enrollment isn't only about benefits changes, it's about your exit timeline. If you're on Medicare Advantage and already managing a condition, the door may be narrower than it was. Document every prior authorization denial. Understand your appeal rights. Know that federal guaranteed issue rights exist if your plan exits your service area. And know that original Medicare without a supplement is not a safe landing. Don't leave one exposure for a larger one. The woman from the opening didn't make a foolish decision at 65. She made a reasonable one with the information she had. The information she didn't have about underwriting, about the one-way door, about what a cancer diagnosis would mean for her options 4 years later. That information existed. It just wasn't in the commercial. And that gap between what's in the commercial and what's in this video is exactly why this channel exists. This channel has no connection to any insurance company, Medicare, or any government agency. Nothing here is medical, legal, or financial advice. It's the context that tends to get left out of the sales conversation. If something in this video applies to your situation, bring it to a licensed independent Medicare counselor or contact your state health insurance assistance program, SHIP, which provides free, unbiased guidance at no cost to you. Episode 1 covered the $0 premium entry point. This episode covered what happens after. Coming episodes will go deeper on the appeals process, how to read a summary of benefits before it's too late, and the specific plan mechanics that determine whether a denial sticks or doesn't.